Welcome to Incorporating SGLT-2 Inhibitors into the Management of Patients with Type 2 Diabetes, presented by University of Cincinnati at Diabetes Series Live. My name is Dr. Richard Beezer, and I'm Associate Clinical Professor of Medicine at Harvard Medical School and a Senior Physician at the Joslin Diabetes Center. I'm pleased to serve as Activity Director for this important educational symposium. Activities on Diabetes Series Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box located at the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Mark Stoller, Associate Professor of Clinical Medicine at Northwestern University, Feinberg School of Medicine. Mark, thank you very much for joining us today.
Rich, it's my pleasure to join you today.
As you know, SGLT-2 inhibitors have provided clinicians with another tool to manage hyperglycemia, and a tool that works through a new mechanism. Mark, I know you've prepared an overview on this important new class of medications, and we'll be reviewing that with us in a couple of minutes. So let's start by just giving an overview of what the whole challenge is for people with type 2 diabetes and the multiple mechanisms that lead to the hyperglycemia of type 2 diabetes. And then we'll move into a case discussion that illustrates some of the points.
Great.
Just briefly, these are our disclosures for Dr. Stoller and myself, for those of you that want to make note. Now, to set the stage, there's a number of factors that contribute to the hyperglycemia of type 2 diabetes, and our understanding of this mechanism has led to more and more of these mechanisms being added to this list over the last couple of years. There certainly is an impairment of insulin secretion, either relative to the needs that the body has for insulin quantity, or even an absolute decrease. There's also a decrease in the incretin effect, and a number of medications will target the incretin effect as well. There's increased lipolysis, and there's increased glucose reabsorption in the kidney, and that's what we'll be talking mostly about today. There's also decreased glucose uptake in the muscle, neurotransmitter dysfunction, increased hepatic glucose production, and increased glucagon secretion. And we now understand that all of these factors can contribute to the hyperglycemia of type 2 diabetes, and all of these are really targets of various of the medications that we now have. Today we're going to focus on the kidney, but keep it in the context of the entirety. Mark, why don't you tell us a little bit about the kidney focus?
Thanks, Rich. And I think the difficulty for clinicians in using this class of drugs is that they're used to viewing the kidney as a problem. They're used to thinking about it, how do I prevent damage to the kidney, and have never considered it a therapeutic target. So I'd like to review the role of the kidney in normal individuals, because I think most of us don't appreciate how important it is in glucose metabolism. We think of liver, we think of pancreas, we don't think of kidney. So normal renal physiology. The kidney filters about 180 grams of glucose every day. Now you have to think like a caveman here, because cavemen didn't have continuous access to calories. And so the loss of even 1 gram of glucose would be critical in terms of long-term survival. So the body developed a very efficient mechanism for reabsorbing glucose. We burn about 170 grams a day just for supplying brain and the renal medulla with glucose. Those two organs can't use any other fuel, and therefore the body demands almost perfectly match the reabsorption capacity. Almost all of it gets resorbed in the proximal tubules, and really there's very little glucose that ever appears in the urine in normals. About 90% of that is absorbed by the SGLT-2 mechanism we're going to be talking about today, with the remaining 10% by the SGLT-1 mechanism. But I think what's important to know is that the kidney contributes about 20% of all glucose production and 40% of all gluconeogenesis in the normal individual. So it's the second most important organ after the liver. So you would expect gluconeogenesis and glucose production to go down in type 2 diabetes, especially postprandially. The glucose is already elevated, but it's paradoxically increased. And the renal contribution to hyperglycemia postprandially is quite significant, especially in early diabetes, with a threefold increase in glucose output relative to patients who don't have diabetes. But what happens over time is as renal function declines, that contribution of glucose production declines. And in patients with later stage diabetes, one of the reasons that they're more prone to hypoglycemia, beyond just clearance of medications or insulin, is the fact that the kidney no longer can supply that gluconeogenetic boost to blood sugars. The other thing that happens is, again, paradoxic. In type 2 diabetes, even though blood glucose is elevated, you have increased SGLT-2 expression and activity in the renal tubules, and glucose absorption is actually greater. The threshold for glycosuria is increased. And again, that makes sense from an evolutionary basis, because the body is perceiving hyperglycemia as a catabolic or energy loss state. It's going to upregulate SGLT-2 to try and conserve glucose. So the implications here are that an adaptive response to conserve glucose suddenly becomes dysfunctional in diabetes. And the kidney's ability to conserve glucose actually is augmented by an increase in the renal threshold. It goes up to 240 from the usual 180. And exploiting this mechanism may actually be of benefit to the patient with diabetes. So let's look at how these drugs work. This is just a schema of the filtration of glucose. And again, glucose is filtered by the glomerulus in the kidney. It then moves into the proximal tubule where the SGLT-2 receptors are located, and about 90% of the filtered glucose gets reabsorbed right here. The remaining 10% is in the late segment of the proximal tubule, and that's the SGLT-1 mechanism. Now again, think about, you're used to saying, oh, glucose in the urine is a bad thing. And remember, that's because it was reflective of glucose in the bloodstream. And so it was reflecting how much was filtered. This glucose in the urine is not appearing because more was filtered at the glomerulus. It's just not being reabsorbed. And so therefore, the worry that somehow glucosuria will damage the kidney really isn't founded, because it's a tubular phenomenon, not a glomerulus phenomenon. Here's one other point to remember. When the SGLT-2 inhibitor, or SGLT-2 receptor, reabsorbs glucose, it does so with co-reabsorption of sodium. And so with every molecule of glucose, there's a molecule of sodium that gets reabsorbed. When you block this receptor, suddenly you also block the reabsorption of sodium, and you get a natriuresis. And this contributes a bit to the weight loss, but also a bit to the blood pressure reduction that we'll talk about later that we see with these agents. So, to review SGLT-2 physiology, since we're going to have drugs that block this mechanism, again, the kidney is very busy. It filters about 180 liters of plasma per day, and it filters about 180 grams of glucose during that time. Approximately 160 need to be reabsorbed to meet obligate glucose needs and maintain a normal blood sugar of about 90. The amount of glucose being reabsorbed increases until the blood sugar reaches 180, 190. When this threshold is reached, then glucose begins to appear spontaneously in the urine. It saturates the mechanism. Unfortunately, in patients with type 2 diabetes, the glucose in the urine remains undetected until the blood glucose concentration exceeds that even more, and actually 240 is a typical threshold for patients with diabetes. And so if you can reduce SGLT-2 activity, then glucose will appear in the urine at a much lower glucose, and therefore blood sugar will come down. The selectivity of SGLT-2 inhibitors is important more from a tolerability point of view, because there are SGLT-1 inhibitors in the gut, so that you're no longer absorbing glucose in the gut if you were to block SGLT-1, and therefore GI side effects increase with SGLT-1 inhibition. But these drugs have the unique potential to at least cause a temporary, ongoing negative energy balance. It may correct the effect of glucose toxicity on beta cell function, because lower ambient glucose is lower stress on the beta cell. And I think most importantly, as Rich said, it's a new tool. It's mechanistically and therapeutically additive to existing therapies. And I think as you look at this, look at it from the perspective of it's a non-insulin mediated way of lowering blood glucose. So there's no issues with insulin sensitivity, no issues with insulin secretion.
And you're breaking away from the standard paradigm that we've been stuck with for the last couple of years.
It's different. It allows us a new direction to go in this chess game of many.